start on breathe, and I'm just going to place the probe. So I take out, I select the C2 to 9 probe, and I select a first trimester setting. So the first thing in selecting a first trimester setting is I need to have my sector width so it's maximum, because I want to see to the sides when I'm doing my sweep. So I come down to the cervix, I see the cervical canal, the endocervical, the epithelium, and then I sweep up, I can see there's an anterior placenta. I'm seeing the full uterine cavity, and I'm seeing that there's heart motion, and thanks very much. I see this heart motion, and then I come up to the baby's head, and then I do a longitudinal sweep. I just take that off and split that image. Stuck. Do you think that froze it? Try and finish it. You can't see it really, it's not reading the USB document. Okay. So then do a longitudinal sweep. It's still increasing. Sorry, just having a few technical problems. So I'm going to start again. Okay. Just bear with me for 1 second. So I've done my sweep and a transverse section to the fundus. I then do a split image, and then I just follow it right down to the placenta of the anterior wall, and I can see the cervical canal. So I save that image. I don't know why I did that. What is that? H-E-R, and then I just put it in Simon. Okay, and then put in the due date. Okay, so we start the exam. All right, so I finished doing a sweep, and I can see that there's a single baby, and that there's a heart motion is present. And next I'm just going to start, when I do this sweep, I look to see, well, number one, is the heart in a good position? As a general rule, that's the first thing I do, because if it's not in a good position, then I go and look at something else. But if I feel I can get the anatomy on it, and it's not in a great position for me, it's okay. So I'm just going to do some biometry. So I'm going to come across and try and get a crown lump length measurement, and if I can't get a crown lump length measurement, then I will go to take it the BPD. So the transmission is not as clear as I would like it to be, and this is something you need to consider, consider changing your probe selection. So I'm going to go straight to a probe, which I'm hoping this is the RM7C, it's a nice probe. And I'm just going to see whether this gives me a little bit more penetration. I think it will. Now I'm going to come down to looking at the fetal head. So I'm going to start with the fetal head. And first of all, I can see that there's some subcutaneous edema. So I'm going to magnify the image of the baby's head. And I'm going to take a 4-segment analysis. So I start off by, I'm going to do this before I do my biometry, because I can see my crown lump length is going to be difficult to get. So now I'm going to start off taking the lateral ventricles, and then I come down to the cave valum interpositum, the aqueduct of Sylvius, and then I'm going to come around just to take this cerebral fourth ventricle. You see the way I slightly rotate to bring the cerebral fourth ventricle and the choroid into view? So on this measurement here, again, same as before, I see the cave valum interpositum. I can see the posterior border of the aqueduct of Sylvius to the inner border of the occipital bone is 6, so that's perfectly normal. And I can see here that this is my cerebral fourth ventricle, and that's perfectly normal. It's very important for me to see that cerebral left ventricle is normal, because, and I'll do it again so you understand what it is. I'll measure the generic area trace. This whole space here is the cerebral fourth ventricle. Sorry, my hand's a bit shaky. And this is the choroid of the fourth ventricle. So it's important for you to appreciate that anatomy, because it allows you to see the whole area of the fourth ventricle. Now for me, I much prefer to see the whole area of the fourth ventricle, because if it's dilated, I like seeing this in an axial section because I can see the whole chamber of the fourth ventricle, not just a single mid-sagittal section. So you can see as we look at this that there's edema both anteriorly, just here, and there's edema posteriorly. So on that image there, I'm just going to slightly increase my dynamic range, and I'm going to magnify that image, and I'm going to save that image to hard drive. When you've got in that position, sometimes it's a good exercise is just to increase your dynamic range and then just tap the abdomen. And sometimes you will appreciate, particularly for the patient to understand, if you say you see through behind, and you just tap the baby, and the patient will sometimes understand it much more than just taking a static measurement. From there, I'm just going to go ahead and I'm just going to take some measurements now. So I'm going to start off by taking a BPD. Everybody in the room knows what a BPD looks like. So we just take that measurement with the BPD from view, magnify the image to increase the accuracy, slightly increase the dynamic range. And if you magnify and increase your dynamic range to sharpen your bony edges, you will find that your AI is better. So I'm going to take a measurement of the BPD and measure from the outer to the inner from the BPD measurement, and then from there take the head circumference measurement. Here, important just to include the skull bone, do not include the scalp. It's just the bone when you're taking a head circumference measurement, and then you just enter that measurement. So as I come down from that, I'm just going to come down to the abdomen, and go to the level of the fetal stomach. Now this is going to be a difficult measurement to take because when you look at it, the measurement of the abdominal circumference, if I include the skin edema, I'm going to overestimate it. So in taking this measurement, I'm not going to include the skin edema. I'm going to include what I think is the representative abdominal circumference. Otherwise, I'll get a crazy measurement. And then the next measurement I'm going to come down and take is the femur. I'm looking at both femurs at the same time. So this is the femur on the far side and the femur on the near side. So I'm going to take, when I'm taking a femur length measurement, I like to have a high degree of magnification. I like it occupying 3/4 of my screen. And I like to have it in a perfect transverse position. And once I get in a perfect transverse position, I then just pull back very slightly on my gain, and I slightly increase on my dynamic contrast. And then I go into a femur length, and I take a measurement of the femur length. And I just take the measurement of the epiphysis. And then that will give me a biometric assessment, because when I look at this, it's coming up on the biometry. These are all the measurements coming up. The biometry is 14 weeks and 1 day, and the baby is 14 weeks and 1 day. So it's exactly the same as the last patient. The ultrasound calculation of gestation age was very accurate and very close to it. So the baby is appropriately grown for gestational age, and the first most striking thing when you look at this baby is that it presents with a very increased nuchal translucency. It's not just nuchal translucency, it's scalp edema. So just to get an understanding of what that measurement is, I like to get a measurement of it as to what's the degree, and we're looking at a measurement of 15 millimeters, because I'm translucent. So that's the first measurement that I'll take. So when I have a baby that's presenting with an increased nuchal translucency, the first question I ask myself is this baby hydropic? So I next move down to the chest, and I see in the chest, is the pleural effusions. So if I come down to the four-chamber view of heart, and I magnify the image, I can see that there's a pleural effusion. So I can see that there's fluid accumulated in the base of the lungs on both sides, and I can see there's also fluid surrounding the fetal heart. And then I go down to the fetal abdomen. I see the subcutaneous edema, but there's no ascites. But this baby is hydropic because it's got fluid in more than 2 body cavities. It's got subcutaneous edema, and it has bilateral pleural effusions. I'm going to quickly jump back to my other probe, because the heart is now in a good position. After, when I see a big nuchal after a scene where there's high drops. My second question is does it have a cardiac abnormality? And the third question I have is does it have a skeletal abnormality? So I'm going to move to the heart because I think I can get the 4-chamber view of heart now for a trax. So I'm going to select a preset of a first domestic cardiac. I'm going to come up to the 4-chamber view of heart. I'm going to bring down my sector width and fraction. I'm going to reduce my depth of fraction. And then I'm going to HD zoom. Once I've got the HD zoom in view, I've got a point where I can see the 4 chambers of the heart. I'm just wondering about the contractility of the ventricles. So I'm just going to jump straight to an N mode and just see that the ventricles are contracting normally on the right and left side. And then go back to 2D. And then just magnify that again. And I look at the size of the left and the right cardiac ventricle. And I split the image in 2. I confirm that the stomach is on the left-hand side, and now I do size, axis, rate, rhythm, and situs. So I do SARS. So I then save that image to the screen, and then go back to a 4-chamber view. And once I'm in this, I'm going to go to sub-menu, and I'm going to take a tint device. And then I'm going to come back to my 4-chamber view of heart. Oh, really? Oh, just let me look at the heart. So we look at the 4-chamber view of heart, and next I'm going to run into power Doppler. And in power, I'm going to increase my acoustic output. My PRF is at 17. I need to increase that to 23. Now I've got my option of increasing my color gain. So I'm going to increase the gain. And if I don't get fill on that, and it could be a contractility issue, then I can bring down my PRF to get more fill. And I can pull back on my gain. And then once I've done that, I've demonstrated the cardiac inflow. And then I look at the 3-vessel tracheal view. And I can see in the 3-vessel tracheal view that I have a normal pulmonary artery. And in fact, I can see it in 2D. Just let me take off color for a second. I can see this is the main pulmonary artery, this is the aorta and the SVC. So in this baby, even without the color, I can see that the diaphragms look normal. So I want to look at the pulmonary valve. I want to see whether there's laminar flow. But I'm being told I have to stop here, so let me stop. Yeah, I have to stop. Yeah, or do you want me to keep going? Stop. Stop. I've been told I'm allowed just for another minute or 2. So let's just keep going. So that's okay.
Vâng, thưa thầy, thầy có khoảng còn 10 phút nữa, không phải 20 phút, các bạn đồng ý không ạ? Như vậy là trước tiên cho hôm nay và thầy Sang rất nhiệt tình ạ. Vâng, xin mời thầy.
Okay, thank you very much. And so next I want